तू खड़े नहीं मैंने तो जो नहीं कि नवाज नहीं है just
No.
it has been
Oh,
yeah
एक को नहीं की
no this is all muted तो जो muted होंगे
Oh, then it's fine.
जा चलो हम तो खड़े बंद कराई दो.
All right, we are about time. We have all, around 30 participants who have joined this call today. And today we are going to talk about the myths and about the COVID vaccines and stuff.
People will stream in. Go ahead.
Yeah, so I would first of all like to invite, and actually, I would like to wish all the Cogen members a very happy New Year. Thanks for attending this session. We hope that you all are safe and healthy wherever you are. Today's session, thanks to Louis Bhai to help us put up this session and coordinate with Dr. Nirav. Dr. Nirav Shah is our fellow Kutchi member. He's from Gam, Kodai. Nirav Shah is an infectious disease physician at North Shore University Health System and a clinical assistant professor at the University of Chicago, Pritzker School of Medicine. He's also a medical director of quality innovation and clinical practice analytics, and the program director of outcomes research for quality and transformation. Nirav has been involved in the COVID response by working on clinical trials for Remdesivir and Regeneron antibodies. I hope I pronounced them correctly. And he's also been helpful with setting up research infrastructure and more efficiently enroll COVID patients into clinical trials. He's also been performing research on COVID-19 diagnostics and epidemiology and helping with the North Shore university systems to recover from COVID. So with this, I just wanted to let you all know the format for today. We'll have Nirav present the slides and he'll talk through his slides and give us a lot of information. And of course, a lot of us will have questions. So I'm sure or most of these questions will be answered while he's doing his presentation. And if you still have any questions at the end of the session, you can always put them in the chat window. Or you can raise your hand from the options below and I'll unmute you and have you speak up the question as well. So with this, Nirav, floor is all yours. Please go ahead. And thank you once again, Nirav, for doing this session for all of us. I really appreciate it.
Thank you, Mitul Bhai. Can you guys hear me?
Yeah.
Yep.
Very clear, yeah.
Yeah, morning, everyone, or morning or afternoon, wherever you guys are from. It's my pleasure to kind of give this talk. This is probably my 8th or 9th talk that I've given to a large kind of audience in the past year and a half. Well, I would say year. I usually give these talks when I'm prompted by family members and friends that start having a lot of questions as to what's going on. And with the COVID vaccine rollout, I've been getting kind of an extraordinary number of questions. And, this is something where I'm hoping to kind of give you some information. It's hard to figure out what's going on because not all of the information is in one spot. So hopefully I'll be able to give you a lot of information about a lot of stuff that's going on. And we can go from there. Like Mitul Bhai said, my background is in infectious disease, but I've been working on a lot of things related to COVID because I have roles in analytics, informatics, research, quality. So I'm looking at it from a wide public health as well. I'm looking at it from a wide variety of lenses. And so I'll try to provide you with that lens kind of going forward. So this is going to be the structure of the talk. I'll talk about the epidemiology, treatments, focus on the vaccines, a little bit on the other variants. and we'll leave a lot of time for questions. So I'm happy to stick around until all the questions are answered. And I know that in previous talks, we've had quite a few questions. So definitely you can write them in the chat function when they come. Okay. So a little bit about the epidemiology. This is about what's going on globally and nationally. So this is the most recent. So all the data is updated as of today. So we have 89 million cases. The U.S. has 21 million cases. India has 10 million cases, the top two countries. And global deaths, you see that the U.S. is at 368,000 deaths. I gave this talk 2 weeks ago, and everything was about 10 to 15% lower in terms of total cases, total U.S. cases, total U.S. deaths. So it's quite, if anything, things have been accelerating, in this winter time period. And you can see that, and this is global, you can see there's this little uptick, in terms of global cases. This is from the New York Times, and it basically shows kind of what is the number of cases that have been occurring. And if you look here, we're getting close to 300,000. And on January 8th, there was 300,000 cases. That was the first time we breached 300,000. So if anything, this little bump right here is from the holiday travel that everyone basically said, try to stay at home and don't try to travel. That's basically where this is coming from right now. This is a map of the prevalence of the infection throughout the U.S. And you can see that it is just basically everywhere. There's not a single area that has been untouched by this. I think a few weeks ago, Antarctica was the last continent that had it, and there was an outbreak in this research group as well. So this has affected everybody in the U.S., in the world. No place is kind of is spared from this. You can see that there are some areas that are real hotspots. You can see California, Arizona, Kansas, Oklahoma, North Dakota, South Dakota used to have quite a bit. They've kind of burned out. I mean, there's certain areas that are still dark. And then you see the Midwest is still quite high, and the South is starting to become a hotspot. I'd like to show this. This was what this looked like in about April, May, June, right when things had been locked down, and then there was an interest in kind of reopening probably a little too soon. You can see that it wasn't, it was still kind of in sparse areas. It hadn't really gone anywhere. So now it's kind of distributed throughout the US. This just gets at, an issue that's occurring kind of in the healthcare system. It's the shares of ICU beds occupied. And the red dots basically mean that the ICUs are essentially full. The yellowish means that the ICUs are at about 75% capacity. And you can see essentially in California, and then if you just take a line going south, you can see that there is a lot of red everywhere. So a lot of hospitals are essentially completely full, and they're having to deal with decisions around rationing care. So that's an important thing to kind of understand of how this has affected kind of the healthcare system, and that affects kind of not only COVID patients, but every patient that comes into the hospital if you need care. This gets at some of the mitigation that states are doing. As you can see, it's a patchwork. There is not a federal national response to this. So businesses being closed, you can see there's a handful of states that are closed. Some are mixed. Mask usage has gone up as essentially as this fall outbreak has occurred. Mask usage has gone over 70%. It's not at 100%. There's still some places that don't have restrictions. But that, there's very clear data that using masks saved lives, but still there are places that don't have restrictions. And then there's a few states that have stay-at-home orders as well, or advisories. And you can see that there is, based on where you live, there may not be some correlation between how strict some of the mitigation efforts are done at your state level and where the epidemic is. So for example, there might be some folks here from California. Businesses are mostly closed. Everyone's wearing masks. There's stay-at-home orders, but why is it spiking so high? There's probably a lot of reasons why that is. There's probably some of that new variant maybe attributable to that. And then if you look at cell phone data, mobility data, looking at to see if people are actually staying at home. It's probably not as strict as, even with all these stay-at-home orders and masks, people are still kind of quite mobile. And that's probably one of the factors contributing to as well to kind of the high rates in California. This is some of the projections. So I show this to basically state that we are still a long ways to go. The vaccine has rolled out. That doesn't mean the epidemic is done and that, we're gonna, this is a silver bullet. So, IHME is a group out of University of Washington. They are probably one of the leading analytics groups that is modeling COVID. And so they're projecting that up to 731,000 Americans could die of COVID by April 1st if states begin to ease mandates and a vaccine isn't rolled out as planned. I think I told you that we're around 360,000 or so. So they're predicting this to double. And if anything, as we're seeing, things are accelerating right now. More than 45,000 lives could be saved if the vaccine is distributed faster than planned. And there could be 49,000 fewer deaths from the virus with universal mask wearing. So there are things that can be done to reduce this, but we're already on a trajectory where they're expecting around, in the best case scenario, with 100% masks, improved rollout, they're still expecting over 500,000 deaths by April. So we are still in the midst of the pandemic. We still have a while to go. And then with the vaccine rollout, continued mandate, they predict 567,000 deaths. And they said that nation mask wearing is now at 74%, which is, like I mentioned, as you see family members, friends getting sick, that rate is starting to go up, but it's not 100%. This is, it's a nice picture, but what I want to show from this is, this was out of the journal Science, which is one of the leading science journals, in the world, I would say. What they did was they looked at the last conference that went through in the US. It was a biotech conference in Boston. It happened somewhere around February or so. And there were about 100 or so people who became infected as a result of that conference. And what they did was they sequenced essentially that type of coronavirus, and then they sequenced it later, a few months ago. And what they showed was that about 330,000 cases were attributed to those initial 100 or so cases. So by getting infected, it doesn't just affect you, it affects people further down. And there's a lot of stories where, family members go out to eat or go out to meet with people, and the people that are affected are not them, but they're family members that are older or have immune issues or something like that. So the point of this is really to say that we are all kind of connected. This is something that, while you may feel that you are safe because of your age or something like that, your actions can potentially have devastating effects further downstream, with loved ones or friends or family. I just wanted to give a little bit of information kind of on the disparate risk that South Asians have specifically. So this is some research that was done by electronic health record company Epic, and then some groups. And so they basically showed, if you look at the total number of hospitalizations and deaths, that Asians essentially have kind of a high risk. So even though we don't make it that much of the population, if you look at the number, our hospitalization rate, and you compare it to our death rate for a given patient that's hospitalized, South Asians are at a very high risk of dying. And this is some data as well that hasn't been published, but is kind of in the preprint area where it hasn't been peer reviewed, but it basically showed that South Asians and Chinese are at a higher risk of COVID. And so if you look at South Asian as this blue color, so the likelihood of having a positive test for those who are tested, South Asians are right up there with Hispanic. If you look at hospitalized, South Asians are right up there with African Americans. And we're a little bit lower in terms of who died. We actually see Chinese are at high risk of death. But there is a disparate risk that South Asians have. And some of the drivers are that in the South Asian community is that there's unequal access and there's barriers to healthcare and public health messages. In the US, there's some qualitative data that suggests that there's fears due to immigration, cost discrimination, delays seeking testing and healthcare, and delays might lead to worse outcomes. And then common barriers to COVID prevention in South Asian communities are immigration status, language, occupation type. So it's actually on both sides. You know, there's a group that literally is on the front lines, whether they're Uber, Lyft drivers, they're store owners, but then there's also the, you know, a physician type community, nursing type community. So kind of on both ends, there's a lot of occupational type risk. There's a lack of protective equipment, housing, and intergenerational families, which is a big thing in South Asian families. And then on top of that, we have high risk for some underlying risk factors: diabetes, high blood pressure, heart disease, and that basically puts us at higher risk for severe disease. So what are the things that we can do? These things you've heard from the very early days of COVID: masks, incredibly important, social distancing, monitor for symptoms and stay home. If you're sick, wash your hands. Stay home and avoid large and small gatherings. That's kind of a critical thing. That's really where the spread is coming. And if you think that you have a bubble, your bubble is actually, and it's a tight bubble, your bubble is actually a lot larger than you think. And it is, you may think that you only see 2, 3 people, 4 or 5 people, but those people could have kids in daycare, or could have, you know, be going out to the gym. So, you know, your bubble is not as big as you think it is. And even after vaccination, you will need to wear masks and consider distancing. And I think I'll get into that a little bit later. So let's go into the treatment. This will be kind of just a quick, discussion of what treatment options are available. And I get it, and I wanted to include this because people are still getting infected, and for you to have this information could be the difference between getting, you know, a life-saving type of therapy. So just some basic: about 80% of people recover from this disease without needing special treatment, but that means 20% do need treatment, you know, may be hospitalized. So that's a high rate. And if you think about, this is just a very rudimentary kind of picture that describes kind of the infection. So if you are, say you get exposed and you're infected, there's 2 phases. There's the viral phase and the inflammatory phase. The viral phase is kind of what you feel when you first get infected. You may have fevers and chills and muscle aches and GI symptoms, stomach aches and nausea and vomiting, diarrhea, all that kind of stuff. But then there's this phase that occurs around day 5 through 8, where you can get what's called hypoxia, which means your oxygen level goes down. You can develop pneumonia. You can develop all these more serious kind of medical terms, like ARDS means when your lungs just basically fail, multi-organ failure. So that's the inflammatory phase. And so there's 2 types of phases, and the treatments really are targeting these 2 different types of phases. And treatments that work in one phase may not work in the other phase and may cause harm in the other phase, and vice versa. So this is kind of an important distinction as we go through the treatments. This is the New York Times has a lot of information that's updated continuously, and they aggregate information so well. So there's one treatment that's FDA approved, 2 that are widely used, 2 that have promising evidence, and there's a bunch where there's tentative or mixed evidence. 2 things that are widely used. These are maneuvers, not really drug therapies, but prone positioning. This means when you lay flat on your stomach. I've gotten a lot of questions from family and friends. You know, I just got COVID. Should I lay on my stomach? This is not something that you do at home. This is really if you're in this inflammatory phase, or if you're already in the hospital, that's when prone positioning is helpful. So if you get COVID, you don't need to rest on your belly when you're, you know, resting at home. Ventilators and other respiratory devices are life-saving as well. So these are 2 of the drugs that have promising evidence. So dexamethasone and other corticosteroids. There were studies out of the UK that basically showed that giving steroids, specifically dexamethasone, reduced death by about 30%. And that is really only if you have hypoxia, meaning if your oxygen saturation goes down and you require supplemental oxygen, meaning you require oxygen to help you breathe. Not necessarily the ventilator, but just a nasal cannula or a mask to help you breathe. That's the population where this may benefit patients. What we found is if you give steroids in the viral phase or early, you may actually be at risk of death. So I've gotten tons of questions about this too. So if you get infected, you don't want to take steroids. You want your physician to tell you when to take steroids, and there are clear guidelines. Otherwise, it could be harmful. There's another drug, remdesivir. I've been involved in some of the studies and will be involved in some in the near future. This is an antiviral drug. There was one study that basically showed it might reduce the recovery time of people hospitalized from 15 to 11 days. There was a study a national study out of from the WHO that showed it had no benefit. So it's not really clear in hospitalized patients if there is a benefit of this drug. The thought is the sooner you give it, the better. So, so there are studies actively going on where they're trying to figure out if we give this to someone before they go to the hospital, can this prevent them from getting hospitalized or having a severe infection? So that's ongoing. There's two drugs or two therapeutics that have been coming up in the news quite a bit recently. So one is convalescent plasma. What that means is if I get infected and I develop my own antibodies to coronavirus, I can donate my plasma. And that plasma has a lot of these antibodies that that essentially target and neutralize the virus when it comes in and affects someone else. So there have been some studies that have looked at this in severe patients in the hospital. There's mixed results. The emergency use authorization that occurred some time ago was probably a political issue more than anything else than based on science, so it probably shouldn't have happened. But there was a recent study that came out of Argentina that shows that if you give convalescent plasma in patients that have COVID and have been symptomatic for about 3 days, if you give it within 3 days, it reduces your likelihood of being hospitalized and having a severe infection by about 50%. That was a very rigorous study, so it suggests what we would expect scientifically, that this therapy is probably helpful, but you require it sooner rather than later. The next category is monoclonal antibodies. These are the two companies that have these are Regeneron and Eli Lilly. So they have these monoclonal antibodies. So studies that have looked at treating patients, and what a monoclonal antibody is, they looked at all the different antibodies that were being produced by people who had this infection, and they targeted one or two that looked like it would be really effective in neutralizing the virus. And then they created synthetic antibodies. And so they're administering those in patients. And what they found is in patients that were hospitalized and sick, this really doesn't have much value. And it's really because they're already in the inflammatory phase. The virus has already done its damage. And really the issue is the body is attacking. The virus has already done its work and the body's attacking itself. So the monoclonal antibodies haven't been helpful, but where they've been helpful is really early on. And so there's been some studies from Regeneron and Eli Lilly that have shown 50 to 70% reduction in hospitalization. And the reason why I included this is because these therapeutics are available in hospitals. The federal government bought around 300,000 doses of this and have basically deployed this to all hospitals. So when someone tells me they get infected, the first thing I ask is, how many days from when you started having symptoms? Because the sooner you have symptoms, and the sooner you receive this, the better the outcome. And even though the studies have been small, there's a couple of health systems that have actually shown the same data the same results that those initial studies show, that people are actually getting better. I've given this to quite a few family friends who have asked me, what do I do? Or at least I've told them to go get this. And they say that as soon as they get this, that within a day or so, they feel like they're back to normal. And I actually had a relative who had this, and another family member had the infection as well. And they both ended up going into a clinical trial. One of them got it, one didn't. The person who got it, who was older, ended up feeling better the next day. The person who didn't get the antibody and got the placebo actually felt worse, felt poor for another couple of days. So this is something that is available if you or a loved one gets this infection. As soon as they get it, you need to be on the phone with your doctor to try to get this therapy. And it's being underutilized. People do not know about it. They're not sure what it is. This is a good therapy, and I would get it. There's two therapies that I also get asked about from people from India. Ivermectin, favipiravir. We don't use either of these here because there is not much data. There are clinical trials that are occurring right now, but it's literally given in India to every patient who gets infected. As soon as you have a positive test, they write a script for this. It is unclear that these things work. It works in cells, and there's some evidence in humans, but it's not completely clear yet. The studies are not there yet. vaccine. So this is the bulk of it. So I'm sure all of you guys have heard of Anthony Fauci. He's essentially the head ID doc in the US. I feel extreme confidence in the safety and the efficacy of this vaccine, and I want to encourage everyone who has the opportunity to get vaccinated so that we can have a veil of protection over this country that would end this pandemic. Anthony Fauci has been the head of NIAID probably for as long, probably as close to as long as I've been alive. And his role is really in developing, kind of funding the top, federal and commercial labs that are developing vaccines for a whole host of things. So his specific focus really has been on vaccine development and, kind of doing the research around infectious disease. And he's basically saying a couple things that I think are really important. He has extreme confidence in the safety and efficacy. So safety means this is a safe vaccine, and efficacy means that this will help prevent you from having severe infection. He says that he wants to encourage everyone who has the opportunity to get vaccinated so that we can have a veil of protection and we can end the pandemic. So he's stating that there's a possibility of ending the pandemic with this vaccine. So this goes into kind of where we are in terms of vaccines. We have 3 vaccines approved for full use kind of globally. There's a bunch of vaccines that are being used in earlier limited use. And if you look here, the Pfizer BioNTech mRNA vaccine has been approved in the US via emergency use. Moderna has been approved in the US. We're seeing that the Oxford AstraZeneca has been approved for emergency use in Britain and India and other countries. This is really the one that people think will really kind of make a dent in the pandemic in the global south. So outside of the US, we're really kind of hopeful because of this Oxford AstraZeneca vaccine. I'd like to and then, here's another one, Bharat Biotech. They have an inactivated vaccine that has emergency use in India. There isn't any published data. So there's been a lot of pushback from the medical community in India as to why it was approved for emergency use. But that was something that was approved. This gives you an idea of the share of population that has gotten a shot in the US, 6.7 million people so far. They were hoping to get 20 million vaccines in people's arms by the end of the year. So this has been a very slow rollout. You see that states have varying rates of vaccination. I could probably speak at length as to what has gone wrong, but we'll save it to things that are probably useful for this for this talk. Really, what does a vaccine do when you inject a piece of DNA or protein or the actual inactivated virus? What happens is the body essentially recognizes it, and a couple cells called the B cells essentially recognizes it and produces a protein called an antibody. And the antibody responds when it sees the virus again, and it essentially neutralizes it. So what happens is this antibody blocks this thing called the spike protein. You see the spike, these are all the spikes. And this spike protein is really what's used by the coronavirus virus to latch onto a human cell and to basically inject its genetic material into the cell. So what the antibody does is it prevents it from binding because it neutralizes that. And then there's a whole host of different vaccine platforms. The genetic platform, this kind of platform right here, where you have an RNA inside this lipid nanoparticle, and lipid basically means a fatty particle. This is really what Pfizer and Moderna are, and so they're essentially the same vaccine in my mind. So this is this, and you'll see that there are other types of vaccines that are protein vaccines, and then there's whole virus vaccines, inactivated vaccines, and viral vector vaccines. This is really what we're talking about in the US. So the mode of action, this is a very complicated graphic. Really what I'm trying to show here is that when you're infected, basically the genetic information comes into your cell. The spike protein is made and processed by your own cell. And then what happens is it releases this this information to the immune cells. There's these different types of cells. The B cell is the one, like I mentioned, that produces the antibodies that neutralizes virus. You may have heard that how long does the antibodies last? You know, there's more data coming out that it's going to last longer and longer as we go further. As we have more time from when this pandemic first hit, we'll understand how long this lasts. We're not completely sure. You know, it could last with SARS and MERS. The thought was that this lasts about the immunity, so to speak, lasts, you know, years. With normal coronaviruses, which are typical cold viruses, it lasts a few months. They're thinking this may last a year or longer. But even when the virus neutralizing antibodies go down, there are other parts of your immune system that may recognize this virus. So these are the memory T and B cells. And so that can provide some safety even if the antibodies go down. So the antibodies are not the full story in terms of the immune response. So now getting to the vaccines. So really there's the Pfizer vaccine and the Moderna vaccine. So the studies that have come out are really on this 37,000 patients across both. These were in the intervention arm, so they actually got the vaccine. So they looked at the people who actually got the vaccine. So for Pfizer, it was over age 16. What they looked at was the vaccine, the outcome that they were interested in was not did you have coronavirus. The outcome they looked at was did you have symptomatic infection? So did you have symptomatic infection? So about 95% of people did not develop symptomatic infection after receiving this. Okay, so people could still get the infection and it could still potentially be asymptomatic. We don't know if this blocks that kind of spread of the infection, but we know that it prevents symptomatic infection. There was frequent non-serious adverse effects. I've been getting a lot of calls from family and friends, actually in the last 24 hours even, of people who've gotten the second dose and they're like, oh, I feel wiped out. So that is common. So there's a lot of non-fatal, frequent, non-serious adverse events that are occurring, such as headaches, fever, fatigue, GI symptoms such as abdominal pain. That is occurring, and it occurs usually within a day or two of the first or second dose. And it's really the second dose where you have the first dose. Most people felt like maybe a little fatigue, maybe a little pain in the arm. The second dose, I'm hearing like I'm getting fevers and chills, and it usually lasts about a day or so. They found that really there were some people, let's see, 6 deaths in the study period, 2 vaccine, 4 placebo. All of these were unrelated to the vaccine. So the important thing is that and the same thing is really the case here. Deaths in the study period, 6 vaccine, 7 placebo, unrelated to the vaccine. So these vaccines do not kill you. The coronavirus can kill you, and it can kill people at any age, really. So that is one of the key things that I wanted to stress. And then there's doses administered 21 days apart for Pfizer. Moderna's 28 days. And then the other thing to just talk about Moderna, that was 15,000 patients. They were ages 18 and older. The efficacy was 95%. So again, 95% did not have symptomatic infection. And it was a consistent across age groups. So some people ask, I'm 90 years old, I have diabetes, I have this, is the vaccine still effective? It's effective for everybody that it was studied in. There are some groups of patients where it wasn't studied in, immunosuppressed, so people who are on chemo, people who have immune conditions. It's not clear what the efficacy is there because they were excluded from this. The suspicion is, with all vaccines, is the efficacy will be lower because their immune system may not be as functional, cannot produce these types of antibodies, but that's kind of one of the things that we, that we're thinking. This is one of the most famous graphics of the vaccine study. This was in the New England Journal. And I included the actual graphic to show you kind of what we're seeing with the vaccine and how it works. So the blue line is if you got the Pfizer vaccine. The red line is essentially if you got placebo, meaning you just got just like a saline solution and there was no actual, nothing that was active in it. What you see is the red line is really kind of the rate of infection, and you see that it's pretty linear over however many days. And the blue vaccine, you see that it matches the red, from the first dose. This is day after first dose. For the first about 10 to 14 days, it's about the same as if you get placebo. So if you get the vaccine, you have the same risk as someone who did not get the vaccine for about the first 10 to 14 days. So I know of people as well who got the vaccine and who got the infection right after it because they were still susceptible. So you have to wait about 2 weeks after the second dose to have that 95% efficacy. So as soon as you get the vaccine, you can't be like, I'm taking my trip to, I don't know, to wherever, to Hawaii or Orlando or whatever, because you're still at risk. You can still, or like, I'm going to go eat outside because you're still at risk. So it's very important that you still, if you get the vaccine, whenever you get the vaccine, you have to maintain those same mitigation efforts to protect yourself in this period of time. So the components of the vaccine, there's a lot of misconceptions about what's in the vaccine. There's some basic ingredients. There's actually the mRNA, which is a type of genetic material. There's a lot of genetic material that is foreign, that is floating around in our bodies from various bacteria, various viruses that we're just breathing in and everything. So this mRNA is a completely safe thing. It gets degraded within a day or two. This is what creates the immune response, but it gets degraded. It does not incorporate into your genetic material. It does not cause any kind of future effects because there's genetic material being injected. You have genetic material coming in at all times. We have tons of bacteria living in our system. We have tons of viruses that keep attacking us all the time. So this is not something that will result in long-term effects. Then there's a bunch of fats or lipids, which makes the outer membrane of this so that you can deliver it. And then there's a bunch of salts and sugars. And it's the same thing with the Moderna. You see the same kind of active ingredients, essentially the same. There's some fats, then there's some salts and buffers and acids and sugar. There is some concern that people that are allergic to this polyethylene glycol, it's called PEG. It's the same ingredient. If you ever had a colonoscopy, the stuff that you have to drink, and it's in something called Miralax. So if you've ever had a reaction to that, there could potentially be a reaction to the drug, to the vaccine. So that's one of the things that they're looking at. This is for folks, a lot of people have questions about the allergic reactions related to this because it was in the news. And so what the CDC put out in their, in their journal was that in 1 million or so patients, they had about 11 anaphylactic reactions. So that's severe reactions. I think about, for the majority of them, it happened within 15 minutes and no one died from it. And I think about 2 people had to go to the hospital for overnight observation. So what is the risk? Who needs to be monitored closely? So really, if you have a history of severe allergic reaction, or it's called anaphylaxis, when your throat swells up, your tongue swells up, you can't breathe, to any component of the COVID vaccine, that's when it's a contraindication. So it means do not vaccinate. So if you have that type of reaction, don't get it again. But then if you have a history of severe allergic reaction to another vaccine, or a history of severe allergic reaction to an injectable therapy, you do a risk assessment and you can still get the vaccine, but it would then require a 30-minute observation period of vaccinated. Remember, the risk of anaphylaxis is 1 in 100,000. So this is like on par with getting struck by lightning. That's literally what this is. And the majority of people have a history of severe allergic reactions like anaphylaxis, okay? So it's a very, very safe vaccine. You are more likely to die from COVID than to have a severe reaction from this. For all other, and sorry, just to mention, if you have any other type of allergic reaction, you can consult with, the nurses or physicians who administer this, and you can have up to a 30-minute observation period if you have a history of anaphylaxis due to any other cause. And then most people, 15 minutes is really what you need, okay? So this is a question about, so if I have the infection, how long is my immunity last? There were 2 papers. This was the New England Journal, and this, which is one of the leading journals. This basically showed that antibodies last about 3 months. There's a drop in some people. It holds pretty steady for some other people, but about 3 months. Then a little bit later, we found, this was October 13th, that this actually lasts about 5 to 7 months. We're going to keep getting more information about how long is this going to last. The thought is this is going to last about a year. And there's some thought that the vaccine will actually result in immunity that lasts longer because it doesn't have some of the mechanisms in the actual coronavirus that evades the immune system. So the thought is that the vaccine will result in a more durable, meaning a longer lasting immune response that will protect you. So a little bit about herd immunity. So if you think about it, there's two ways that we get to herd immunity: infection and vaccine. So those are the two key things that will help us determine when will the pandemic stop. But there's another factor that's on the opposite end that we have to think about, and this is what's called the R0. R0 is how infectious, how contagious, what is the ability of this virus to spread. And so these are the three main components that result in what is herd immunity. So herd immunity basically means, when are we going to get back to normal? So that's really the question that everyone is asking, because everyone is fed up with everything that's going on and ready to move on with their lives. So herd immunity, and this is just the definition, refers to the indirect protection from infection conferred to susceptible individuals when a sufficiently large proportion of immune individuals exist in a population. So to give you an example of what this means, so if you have a naive population, meaning no one has had COVID before, and you introduce one person who has the infection, you can see over a period of time, they're going to infect the vast majority of people. Maybe a few people may not be spared, and then some of these people become immune as a result. What happens is, if you have herd immunity, and that's, this percentage, 70%, they're just using that for this example, and someone enters into this system, what happens is you have people blocking this infection from spreading to other susceptible people. And then maybe you infect one person, but then this stops right there. And so you only have like one successful transmission. Most of the people are safe. So that's really what herd immunity is. And that's what the goal is with this vaccination campaign, is to reach it as fast as possible. And if you look at, so this is basically, this is that figure called the R0. The suspicion is that the R0 for COVID-19 is somewhere between 2 and 6. So the thought is that herd immunity will be somewhere between 0.5 and 0.8. If you guys have been listening to the news or listening to Anthony Fauci, you will have heard that he said initially 0.6, so 60% of the population having immunity is kind of key for herd immunity. Then he's gone up to 65%, 70%. The thought is it's probably around 80%. And there's a couple reasons why he did that. One of the things is because, there's a variety of reasons why he did that, but he wanted to slowly kind of move the guard posts, based on the vaccine efficacy, and then understanding what was the vaccine hesitancy in the population. What we've noticed is that a lot of people initially were very hesitant to receive the vaccine, but over time, as people see, physicians and nursing homes getting the vaccine safely, the number of people who want the vaccine has gone up over time. It's still not 100%. It's still low for the sake of herd immunity, but it's going up as people learn about this, and misconceptions and other things get debunked. And then this is the predicted number of deaths. This United States, they're thinking this is somewhere between 600,000 to 1.2 million. This is based essentially on kind of what's the herd immunity rate, et cetera. So, so some common questions related to the COVID vaccine. And so this will just supplement the questions you guys will ask. So how do they develop it so fast? Are you concerned? There's a couple reasons. Actually, there's numerous reasons why this happened in 1 year. A confluence actually of multiple reasons. The first is that so SARS and MERS occurred in the last 15, 20 years. They're two coronaviruses that are very similar to COVID. And essentially what happened is, when these things occurred, the immunology infectious groups, governments, et cetera, started developing vaccines, and they started developing it based on that spike protein. So they had a lot of knowledge, even though those got shut down because those things burned out. They had a lot of knowledge going in as to how to target this type of virus. There's this group called CEPI, which is essentially a large group that's funded through a lot of government organization and other organizations that has been thinking for a while, how do we speed up vaccine development in the event that we have a pandemic? And so they have provided a lot of know-how and capabilities for a lot of governments to rush this process, if something like this occurred. This was the first time where, as vaccines were being developed, production was occurring at the same time. That has never happened before. Usually you wait until the studies are done and then you start producing. So this was done in parallel instead of in series. We've had high rates of infection. In order to test a vaccine, you have to give the vaccine, and then you basically have to see how long does it take for someone to get the infection. And when you have extremely high rates, as we had in the US, it happened in weeks, as opposed to if you had, like, say, I don't know, if you had like shingles or something where you have to wait a long time for someone to develop shingles. So that's another reason why that sped up. And then the genomic advances as well. And there's a bunch of things that I haven't mentioned as well. Are we sure these vaccines are safe? So now there's the 2-month time frame. I actually had this from earlier, but now we have a much longer, like 3-4 months time frame. We're not seeing any kind of long-term side effects. We probably won't see. There may be some long-term side effects, but they're not occurring kind of in the tens of thousands and even the hundreds of thousands of patients that are receiving the vaccine. Well, I would say in the tens of thousands, we're not seeing like long-term side effects at the 3-month range. In terms of are we going to see some side effects that we haven't been exposed to? That's a possibility. We've had about 6 million people get vaccinated. The main thing really is these common fevers, chills, body aches, and then some allergic reactions. We haven't really seen much beyond that. Are we worried about the long-term side effects of injecting synthetic mRNA? I mentioned this before, so not really. Should I worry about which one I get? No. I mean, I would get whichever one is available to you. It doesn't matter which one you get. They're essentially the same. Can I return to normal activities after I get the vaccine? I mentioned this as well. Once you get the vaccine, you literally have to wait until 2 weeks after the second dose. And even after that happens, you're still going to have to wear a mask for quite some time. Why? Because it's not clear if this prevents transmission. We know that 5% of people had symptomatic infection. There's probably a host of those patients who actually had asymptomatic infection. So that piece is not known. So there's still a risk. If I get vaccinated and I have family members and stuff, I can still potentially pass it along. So that's not clear yet. So with that, we still have the recommendation to maintain those precautions. So then there's the cost-benefit analysis. A lot of people are still not interested in the vaccine. There's a couple of things that we could say. So debunk misconceptions, right? There's not a microchip in this vaccine, or other things that can potentially harm you. But if you think about it, there's 95% efficacy. There's no serious infections or death. 2 to 10, and that's related to the vaccine itself. 2 to 10% of people develop symptoms that lasted 1 to 3 days. This allows us to protect family, friends, and community members. And it allows us, if we do this quickly, to return to normal. Whereas if you aren't taking the vaccine, there's about a 1 in 100, 1 in 200 risk of death. And that risk may go up or may go down if you're in a younger age group, but there is still a risk of death. We hear about cases of patients in their 30s and 20s who are still dying of this. So even in that young age group, people are dying. So there's a risk of death at any age group, but the older the age group, the higher the risk of death. There's a risk of hospitalization, ICU, ventilation. Symptoms last about 1 to 2 weeks. There's risk of this thing called long haulers, where you have prolonged symptoms, mental fog, psychosis, heart-related problems that kind of persist. You put family and friends, community at risk, pandemic living, which is not fun. So in my mind, if you look at the cost-benefit analysis, it's a no-brainer, really. The vaccine is really the way to go. Taking a risk with the infection is just, it's like Russian roulette. So when will I get vaccinated? So the consideration, it's a very complex consideration, and there's no right answer to this. So the folks that were involved in this discussion were those that are at highest risk of death, those that are at highest risk of catching COVID, and those that are critical to maintain infrastructure. The group that did this was really the group that determines, vaccine guidelines for all vaccines, the ACIP. So they're phasing it in 3 phases. So phase 1A is offered to healthcare personnel and residents of long-term care facilities. That's about 24 million people. Phase 2B, it's COVID vaccine should be offered to persons age greater than or equal to 75 and non-healthcare frontline essential workers, 49 million people. And then in phase 1C, to persons age 65 to 74 years, persons age 16 to 64 years with high-risk medical conditions, and essential workers not included in phase 1B, 129 million people. So that's about 200 million people. This is the guideline. States, as has been the case with everything related to COVID in this administration, these are just guidelines. These are not things that they're not enforcing. So states are going to have different recommendations, based on what their state public health departments think makes the most sense for their state. So we're already seeing, like in Florida, we're seeing kind of vaccines going to different populations. In Illinois, they're lowering from 75 to 65. So at different states, they're doing it slightly differently. So what is the delivery deadline for U.S. vaccine doses? You see that Pfizer and Moderna, they had 45 million doses for December 31st. And then Pfizer Biotech, they're by March, they're going to have another 75. By June, they're going to have another 250 million. And then by July 31st, they're going to have 30 million. So that gets us to 400 million or 200 million people. So that's really the schedule. They're thinking that this is going to take, they're going to get the doses by July. Is it going to actually mean that this is going to be available to everyone by July 31st? As you can tell, their schedule has already been delayed quite a bit due to the lack of infrastructure, communication, and basically logistical support related to these two vaccines that are pretty difficult to actually deploy because they require kind of cold temperature, and this is the first time that they're trying to mass vaccinate people like this as soon as it gets produced. So it's been logistically tricky as well. Not to mention the vaccine hesitancy, the requirement to do 2 doses, within a few weeks apart. So it makes it very complicated. So variants, so what's going on? It's not just England, it's going on in South Africa, the US. So there's this virus variant, which is basically all coronaviruses, all viruses mutate, and the coronavirus is not exempt from that. And we're seeing that there's certain variants of the coronavirus, certain types of coronavirus that have certain specific mutations that are more transmissible. And we're getting more and more information that this is actually this variant that's in England that has now spread throughout Europe, that has spread through the US in multiple states, has spread to Canada, that this is actually significantly more transmissible. And the reason is because there's specific mutations that are resulting in the virus being able to more easily attach onto the cell. And so this was one of the first papers that kind of highlighted this in some mathematical modeling. And so this is the new variant, and this is the different proteins in the spike protein, which is the protein that affects our ability to target it with the with essentially the monoclonal antibody with a vaccine, which is what everything is targeting, the spike protein. We're seeing a variety of different mutations there. Pfizer just came out, I think, in the last day or two, saying that their vaccine is not going to be affected by this new variant. Pfizer actually has the ability, and all these new mRNA platforms, they have the ability to turn around a new vaccine within 6 weeks, given that their system is already kind of developed. But lots of variants are known globally. There's this new strain, I mentioned, this is the UK one. It does not appear to affect severity of disease. It's in the US. It's already been shown to be in a few states. I think Florida, California, I think Colorado. There may be more. Will it affect immunity to virus? No. There's a separate variant in South Africa, which is similar in that it results in a high viral load in the nose, and that's resulting in higher spread. There's one variant that has the ability to really reduce the efficacy of the monoclonal antibody therapies and the vaccines, but that seems to be not increasing in the number, in the prevalence of it. It's around 0.5, but it is very low, and it doesn't seem to be taking over all these other variants. So there's a lot of things that are being monitored. The US has a very low capacity for this, but they're building that up so that they can make sure that they can stay one step ahead. But that's some of the information around the variant. So with that is a whirlwind tour through all things COVID. So hopefully this was helpful. Happy to answer questions as long as people have questions.
Okay. Thank you, Nirav. This is a really very good insight of what the vaccines are and how things are progressing ahead. So I'll go through the questions that are already in the chat. So the first question is, do you know if India's infection rate is going down because of the mask use? And I would just like to ask, add something to this question as well. How does the immunity play the role for between India and US people as well? So if you can answer that question.
Yeah, there's a couple thoughts behind this. So the thought is actually a lot of the public health folks that look at the data in India are actually quite surprised that the rates are going down. I think a lot of people are surprised at how India has been kind of spared. And there's a few thoughts. One is that India is a young country. So 50% of the population is younger than 35, right? So we are a much older country. So the majority of people who are dying are people who are nursing home patients who are over the age of 80 or 70. So that's one of the things that's I think helping India in terms of the death rate. The other thing is there's some thoughts that there are other coronaviruses that may have circulated that may provide some benefit, and so that the severity is not as bad. There is some thoughts that the BCG vaccine may help prevent that or prevent a severe infection. And then there's some thoughts around kind of hygiene therapy. You know, if you are exposed to more kind of viruses or unhygienic kind of situations, you're probably a little bit less susceptible to this type of, and that goes to like, you know, are there other coronaviruses circulating that may have prevented it? I can honestly say there's not great mask usage in India. Just like watching Indian TV or anything, you can see that masks are worn like on the beard, you know, like up here. I mean, it's all over the place. So even if people are wearing masks, it's not really effective use of masks. So I don't think that's really the case.
The other question is from what, so this question states, from what I understand, most of the studies and trials are done on 16 years and older. What about giving vaccines to younger kids? Is it safe for them?
So yeah, so Pfizer was 16 and older, Moderna was 18 and older. The suspicion is it's probably going to be safe for kids, but what they usually do is they do it. I mean, especially for this, they did it in elderly, adults, because they needed to get that out as fast as possible. You learn stuff about the vaccine when you give it to a bunch of people, and then you start vaccinating kids a little bit later because they're less susceptible to coronavirus. Oh, and that reminds me, one of the UK variant, the thought is it may actually make kids more susceptible. The studies for actually doing this in kids are active right now. So there's a bunch of studies that are occurring. We're potentially going to our hospital is potentially going to participate in some of these studies around children, but those studies will happen fairly quickly given the high rates of this, and then kids will be vaccinated fairly soon.
Okay. The question is, so while I'm reading out the questions, I see a lot of people have raised hands. So I will have them unmuted once all the questions are asked. And of course, if any of the attendees have any questions, feel free to raise your hands and I'll unmute all of them and they can go ahead and ask their questions. The next question is, appreciate your thoughts about COVID virus and people with O blood group showing higher resistance on virus, ? And then there is some research conducted as I hear. How about a resist factor plays a role?
How about what?
Resist factor.
What was the last part?
Plays a role. So this came from Indu and
resist factor. Oh, okay. Yeah. Okay, got it. There are some associations. You know, when you take large data sets and you do mathematical kind of modeling and stuff, there are certain things that pop up that you wouldn't expect. But then when you look at the mechanism of the virus, it may make sense. So there are some blood groups that may offer some protection. We find that there is a large component. The way that the virus works, it not only targets the lungs and the heart, but it also affects the blood system, and so it results in clotting and other things. So I'm unclear as to what the mechanism is exactly. That's really kind of the hematologists are, evaluating that, and immunologists. But there are various risk factors or protective factors that are around blood-related, I guess, markers. So I'm not sure about the rhesus factor.
So what about the question about the O blood group? Specific to different blood groups, how the virus affects, basically?
Yeah, I don't know the exact mechanism. I mean, the way that they found this was they had a essentially mathematical modeling. They assessed as many possible risk factors, and then they threw this in as well, and then they found that association. And so they probably have worked out some kind of pathway biologically, because this virus does affect the blood system. It causes clotting, it causes all kinds of things in the blood. So there's probably some effect related to that that provides potentially some protective nature to the virus. I don't know what the exact mechanism is.
So the next question is the COVID vaccine will have to be taken every year, just like the flu shots, as the virus keeps mutating so quickly?
It's a good question. So it's not clear how frequent this will have to be taken. The suspicion is that this may have to be taken a couple more times before our body recognizes this to the point where it turns into a regular cold. I mean, so this is just one of like 6 or 7 circulating coronaviruses. And so the other 5 or 6 circulating coronaviruses were introduced into the human population at some point in our history the same way, through some kind of animal. And initially that probably caused, it may have caused severe infection and stuff like that. But as your body has a memory of this type of virus, I showed you there's B cells and the other memory cells. So as you get this virus again, even if it's affected a little bit, like mutated a little bit, you still recognize it a little bit. It's like somebody who goes, to the barber, gets their haircut. You still recognize them. They may look a little bit different. So it's the same thing. Your immune system recognizes it. And so eventually it gets to the point where the body can tolerate it, and it just turns into a regular cold virus. So it's not clear how many times that's going to happen, how long the immunity lasts. The thought is it's more than a year, but how long beyond that, no one knows. It just takes time to figure that out, right? Because it's only been a year or so since the virus has started circulating. But that's the point. It may be that we get this with a flu shot yearly or every 2 years until this no longer starts, causing a lot of death.
And then there's a follow-up question on that. So any information on vaccine that has been administered in Russia and China, effectiveness, and how are these similar and different with the Pfizer and Moderna vaccines?
Yeah, let me just, let me go back up here. So there's the Gamaleya right here. So it's had some early use. They're saying that it's fairly effective. I don't think there is actually data that that has been published, so it's unclear, what the efficacy is. I think China just released some data on Sinopharm or Sinovac, where it was around 70 to 80% effective. So far, really, the most effective vaccines are the mRNA platform. And I mean, these are essentially the exact same thing. And that's the 95. The Oxford can get up to like 90-ish when you get 2 doses of it as well. So that's hopefully that answers your question. It's they're not going to be approved here, until the data is all made clear. And the U.S. has not bought any of those vaccines, so it's not going to really be approved here. And the data is not fully available for scientists to review it, so it's unclear.
So while you're on that particular screen, there's another question related to the Bharat Biotech, which I see is at the end. So the question is, Dr. Nirav, do you have any information on the vaccine that Bharat Biotech is working on? Does their nasal vaccine idea hold promise?
Yeah, I mean they're using an inactivated coronavirus vaccine template, which means that they take coronavirus, they inactivate it, so they kill it, and then so that it can't reproduce. I mean, not they don't kill it, but they basically make it so that it can't reproduce and turn into an infection, and then they inject it. So that's what the flu vaccine is, and so the platform seems like it should work. The problem is that they haven't published, or they may be in the midst of their phase 3, and so that's the rigor in which the scientific community requires this is that you do the study, you publish the data, then you know what's going on, and for that specific way that you run the study, that's how you need to administer it, and that's how you need to do it. We don't have that information for Bharat Biotech, and so it's not clear what the efficacy is. It's not clear what the safety is. It's just not clear. So they approved it without publishing or reviewing the final data to understand all of that.
The other question is if Pfizer and Moderna vaccines are considered the same, why can't the second dose be of a different manufacturer than the first one?
We don't know. I mean, we didn't do a study where we compared the two, so it's not clear if the efficacy goes down or not. When I mean they're the same platform. They're not the same. They're not the exact same, right? There's some differences probably to the mRNA, differences to the fatty stuff. There's the fatty outer particle, and even the salts and everything. So it's not completely the same, and you could probably interchange them and get some benefit. But the question is we can't tell you. We know that if you give the Pfizer vaccine with this many weeks or the Moderna with this many weeks, you'll receive that 95%. It's not clear for any other, even if you delay it by 2 weeks or 3 weeks or a month, or if you get it too soon, or if you switch or swap, we can't tell you what the efficacy is. We just don't have the data. So that's really what the scientific community says. You can do it, but we don't know. Will you have the same protection? Maybe. Will it result in lower protection? Potentially. Can that result in developing more mutations if the population does that down the road? Potentially. So we just don't know.
So the question is, if someone was exposed to coronavirus, like doctors or frontline workers, are they seeing more milder reactions from vaccines, like soreness, fever, compared to those who are not exposed to coronavirus? I've heard some older people who got vaccines have no reaction versus doctors and friends with some mild reactions.
It's not clear. I mean, even in the trials, they had people who had been infected previously. So I think there's probably a lot of variation in terms of the immune reaction to this. And the more severe the reaction, the more robust the immune response. But it's probably loosely correlated, meaning if me and if you made it, like someone else my age got it, we can potentially have different reactions, but potentially could still have the same immune response. I mean, so it's unclear. So the thought is that as you get exposed to this more and more, you have less of a reaction. But the thinking and the question makes a lot of sense, but it's just unknown.
How will the slow rate of vaccine affect a return to normalcy?
Right. So that gets to the whole question of herd immunity. So if it takes longer to deploy the vaccine, that means that we haven't reached that herd immunity, so people can still get infected, and people will still pass this along, and people will still die. So as long as healthcare systems are completely getting crushed by the coronavirus and people are afraid to go out, we can't get to normalcy. And if we don't reach herd immunity, we don't get to normalcy. So the faster we get to herd immunity, the faster we return to normalcy.
So this probably would have you already answered it, but I'm just going to read it out. Is Bharat Biotech getting data input from outside sources like SITE to have authentic results soon? Do you think India is poised to launch a vaccination campaign with a number of trained people and amount of dosages required?
So I don't know. I don't know the first part to the question, the getting data input from outside sources. So I haven't read up much about that other than the fact that there's no data that's available. Do I think India is poised for the launch of vaccination campaign? I mean, I think India has done quite a bit in terms of vaccinations, and they do it on a large scale, and they do it really well. And the benefit of using the Oxford platform is it doesn't require that kind of cooling infrastructure that had to be developed in the U.S. So my thought is that is something I think India is going to do a really good job, in terms of the logistics and getting it out, because they have a template for doing it. They don't need to change it too much, because of the logistics will be fairly similar. So my suspicion is they're going to do quite well once they start getting rolling.
And then again, this is again related to the India vaccines and information on Johnson vaccine.
Yeah, Johnson & Johnson, that's the, it's an adenovirus platform, and it's a 1 dose. I mean, it's still in the phase 3 trial, so we don't have data. We have phase 1, phase 2 data that shows that it works and is safe. The interesting thing about it is it's a 1 shot. So that's kind of interesting because the 2 shots introduces significant complexity.
The other question are on the chats. Which vaccine is better for US? So I believe they're asking between Moderna and Pfizer. I think you already answered that both are the same, but if you want to just add something to it.
Both the same. I would take whichever one you get.
Okay. Then there's another question from one of the members is, I took the Moderna vaccine first dose, and that night I was tested positive for COVID-19. So now, what after the first dose tested positive? So will the second vaccine be still okay? Can I take the second dose?
It's a good question. So you're essentially, I think it will probably confer no additional benefit. I mean, I don't know. I've had friends and stuff who have had the same issue where they got the vaccine and got infected. I mean, so your body is revving up for the vaccine, and then it sees the actual infection, but then the infection, because you had it the same day. Because you had it the same day, I mean, you're essentially infected, and the vaccine hasn't had enough time to do its work for your immunity to develop. So, I mean, I think you could potentially get it. I would say get it if you can, more than anything, to have the card that says that you have 2 doses. Will it confer additional benefit? Probably not. Maybe it will. Maybe I don't know. I mean, they're saying that the vaccine potentially has better and longer durability of immune response, but the problem is you will already have the coronavirus itself. So it's unclear which one will win out. I mean, there's no data to understand this.
Will annual booster shots be required with this vaccine?
Potentially, especially, I mean, it's possible. We'll have to see. It depends on the durability of the immune response, and it depends also on the variants. So if we, with a lot of virus around, there's a lot of virus that can mutate, and so there's a lot of potential for mutant variants that can, cause, be a little bit. That can evade essentially your immune response, to the current vaccine that we have. So there may be a booster that comes in the future because there's now a virus variant that is not being affected by the current vaccine, and so we may have to give something that's a little bit different. So something like that, or if we start to lose our immune response to it. So probably, I don't know if it's going to be in a year, if it's 2 years, but I'm pretty sure that we'll be vaccinated again for this.
Yeah. So this question is not, but I think it's not listed, but it's my question basically. So this is again not related to the coronavirus as such, but what is your thoughts on the flu shots that people ask? That are generally offered, and people say, hey, you should generally take your flu shots. So there are also a lot of myth that flu shots doesn't really have too much protection that generally people need for for day-to-day allergies and stuff. So what is your thoughts on those things? Again, this is not related to COVID as such, but just your thoughts.
There's a TED Talk that looked at a bunch of elderly people, and they were like very old people, or they looked at old people and then followed them, and they looked at what were the things that were associated with longevity. And in the top 10 was a flu shot. So a flu shot is extremely important. And it's not just for preventing the flu, because the flu can cause a lot of different things. It's kind of like coronavirus. So it can cause heart attacks. It can cause COPD exacerbations. It can cause dementia. If you have frequent attacks of the flu, it can cause dementia. So the flu vaccine has been associated with is protective against dementia. It's protective against heart disease. I mean, so people who take the flu vaccine are less likely to have heart attacks, less likely to have COPD exacerbations, less likely to go into the hospital with flu. And as you build up your immunity, as I get the vaccine every single year, and really, at my age, if I get the flu, it's like no big deal. But the thing is if a pandemic comes along and you have a nice library of flu kind of vaccines, if the next pandemic for flu comes along, and actively there's some avian flu in India right now in the south, what happens is you have potentially some cross reactivity, so you won't have as severe a reaction. So I take it for a bunch of reasons, and I recommend every single person who I see to take the flu shot every single year, because the flu doesn't kill, influenza kills, and you don't want to get dementia, you don't want to get a heart attack. And it's associated with longevity. So, it's just as good as like diet and exercise as getting the flu shot. And that's a lot easier than, trying to put down your jalebi or whatever. so I would say I would get it.
Got it. There are two more questions. One of them is pretty much on the question is, can you tell more about Johnson & Johnson vaccine? I'm not sure if you already have that information.
Yeah, we don't have the safety efficacy because the phase 3 trial is not done. So I think that will, in the next few months, they'll have some data on that.
And then the last question is, before I start people to unmute themselves, is would you be willing to do this presentation in Gujarati?
I mean, I could do it. You're just not going to understand anything that I'm saying because I can't really speak Gujarati.
I'll teach you, don't worry.
Yeah,
I need a translator then.
Okay, I see
I can speak Gujarati.
hands that are raised. So I'm going to start unmuting them. So I see Nipa Nandu. Nipa, Ben, please go ahead and unmute yourself and you can ask your question. And then after that, there is someone with JS also who has raised their hand. I'll also unmute you and you can ask your question after Nipa Ben does. So please go ahead, Nipa.
Yeah. Hi, Dr. Nirav. Thanks for doing this. Appreciate your time. I just have one question. The second question I had, you already answered, but the one question I have is related to the treatments that you mentioned earlier in your presentation. The remdesivir and the steroid and all of the convalescent plasma and all that. Basically, all of those things are being administered in the hospital. And you also said the benefit of all of those treatments is the earlier you give, the better results you have with those treatments. Now, unfortunately, whenever somebody gets COVID, the general trend of thought is you stay at home, you have your symptoms are mild, and you stay home and you try to recover. And by the time that it's time for you to go to the hospital, you've already been at home for, let's say, about a week. And this happened with my husband who had contracted COVID, and he was recovering fine at home. And then we had to take him to the hospital around the day 9 or so. And he did get all those treatments in the hospital. He's recovered. He's doing okay. But the point I'm trying to make is that we don't end up going to the hospital early enough because we have been told to stay home and try to recover at home. And by the time the symptoms get worse, it's really too late. You've already passed your 3 or 4 day time limit. So what do you have to say about that? Should people go to the hospital as soon as the symptoms start to show up in order so that you can get these treatments?
So the only treatment you can get actively right now as an outpatient is the antibody treatment, Regeneron antibody and the Eli Lilly antibody. So if you know someone who gets infected and they have symptoms, tell them immediately, go get that antibody as fast as possible. There's a lot of doses, it's already paid for, and you just need to go get that. If you don't get that, and there's a certain number of days pass or you don't qualify for whatever reason, then really the biggest thing is to wait at home, get a pulse ox. And if your pulse ox shows, pulse oximetry is basically a little device, $20. You can get it from any Walgreens, Amazon, anywhere. And you put it on your hand and it tells you your oxygenation level. If that oxygenation level goes down below 93, you need to call your doctor and say, my oxygen level is low. I need to come to the hospital. And that's when you go to the hospital. You also, if you feel extremely poorly and stuff like that, a lot of hospitals are full, so you should talk to your doctor to determine if you should go to the hospital or not, and they can help guide you. But really, yeah, the messaging has been around stay at home, shelter in place, because we haven't had many therapies. And you're right, that's the messaging we now need is as soon as you get the infection, see if you qualify for this antibody therapy, get the antibody therapy. If you don't qualify, then stay at home, get a pulse ox. And if your pulse ox is lower than 93, then come into the hospital because you need oxygen.
Yes, so this antibodies thing was not even aware. This for him, he got infected around the end of October timeframe. So there was no mention of this antibodies treatment.
It was starting to be available at that point. The remdesivir and all these other things, there's clinical trials that you can look up to see if you can potentially get it. You may get a placebo, but it's not being offered generally because the data is not there yet. They're actively working on those trials.
Okay, so it's the antibodies treatment that I should mention if somebody catches it.
Antibody treatment, or if they don't qualify, you can try to look for a clinical trial for convalescent plasma or for another antibody treatment or remdesivir. So you can try those.
Right, but those are only administered in the hospital, and you have to take.
Those are administered through a clinical trial in the outpatient setting. They're administered in the hospital as part of these emergency use authorizations, but they are administered as clinical trials. That's how we got all the data on this. So if you don't have any options and you want to try something, you can go via clinical trial and you can look up, do you have, whatever hospital you have clinical trials and see what's available around you. I would go towards big academic centers because you could potentially get therapies that would otherwise not be available.
Okay, thank you so much.
Mm-hmm.
JS, whoever that person is, I've unmuted them. You can please go ahead and unmute and ask a question. And after that, there is Indu Bhai and Jayabin Shah. You can go ahead and ask your question if there's any. Okay, while we wait, there's other question that has just come up. This is Dr. Mita Peer. Thank you for the excellent presentation. It was very informative. What are the best sources for patient education regarding COVID-19 vaccines to be used by the physicians in practice?
I think WHO, CDC are very good. And then I like New York Times. It's written kind of at a layperson level, and it's very comprehensive as well. That's not one of the your sources that a public health type source, but those would be the three that I would use. And it's helpful to kind of keep up to date, just looking at the New York Times, because they update it instantly with any trial. They summarize it. They have good visualizations. So those would be the three that I would look up.
Okay. This question from Kiran. Kiran, I've actually asked you to unmute. You can go ahead and ask a question. Kiran?
Yeah. Can you go to the slides? Which clinical trial are you suggesting, or repeat or type the name exactly? We might have missed.
Yeah, this isn't a clinical trial. This monoclonal antibody right here, that's the treatment where if you know someone who gets it, tell them immediately within them being symptomatic, go find that, find if your hospital has that, and then ask your primary care doctor to refer you to get that treatment, or figure out, talk to your primary care doctor of how best to get this treatment. There is a lot of extra doses. Certain places are using doses like Houston, Mayo. I think there's a few places where they're really running through the doses because they figured out the way to do it and publicize it. But most people don't know about it. Even physicians don't know about this. They call me and say, what do I do? And I say, go get this. So it's a monoclonal antibody. That's what you do if you get sick. Right now, that's the main treatment offered that has shown 50 to 70% reduction in hospitalization, severe infection.
Thank you very much. It is very, very informative and very good session. Thank you for everything.
Mm-hmm.
So I think these are all the questions so far, and I'm actually unmuting a lot of people here. So if you have any questions, please unmute yourself and you can ask the question before we end the session today. So is there any questions from anyone?
I'm giving my email. If you have any questions, you can email me. I gave a talk to Jana a few weeks ago. I had a few people contact me. I got on the phone and walked them through some stuff. So you can ask me if you have any questions.
Can you hear me?
Yep.
Yes.
Yeah, this is Indubai Shah. So I don't have a question. You already answered my couple of questions, Dr. Shah. It was a very nice seminar or discussion. But I have a comment. Somebody asked a question about when is Johnson & Johnson's vaccine will be available. So I have a little bit of information on that. They are about to complete their phase 3 studies in US, and we are expecting data by end of this month, beginning of February. And if they go for emergency use application with FDA, that vaccine should be available by sometime in March.
Thank you. That's great. Yeah, the less complicated the supply chain and the logistics, the faster we'll be able to vaccinate people. So.
Anyone else? Any questions?
Yeah, I just have one comment to make. And somebody had mentioned about the blood group. I just want to let you know that my husband was blood group O positive, and he did catch COVID, so you can still get it.
Yeah, it's a good point. The protective or risk factors doesn't necessarily mean that you who get the infection will have a less severe or more severe. This is done at the population level. So even if you have even if you're immunosuppressed or have diabetes, you can be asymptomatic. And even if you're normal, young, healthy, you can have a very severe reaction. So it's patient by patient.
Yeah, the question was not about O group not getting virus. Some of the research suggests that if you have a O group, then you are a little bit more resistant to it rather than, compared to other groups, but you can still get it.
Yeah, exactly.
This is Sohail Deshpande. I had a question about the Oxford AstraZeneca vaccine. So there was some data initially when they published, they said that their vaccine was only about 70% effective, and then they reduced their dose, and now they are claiming that their efficacy rate is 90%. So why do you think this has happened, and what is the reason behind it?
I'm not correct, man.
Yeah, I think they mentioned that it was a 70% efficacy rate on one dose and 90% on two doses. That's what I remember from the very beginning. Oxford had a little bit they had some data type issues that lasted a few weeks to months that they've worked out. But it's really the number of doses that you receive, as far as I know. I don't know if other folks, we have some very knowledgeable folks here, so if you have some thoughts on that.
Nitul?
Yeah.
Tell people, or at least let them know that there will be recording available of this to everyone.
Yeah. Like everybody else joined a little bit late. We did get confirmation from Dr. Nirav Shah that we'll be able to share this recording with you guys, with all of you. And also the slides that he has presented, he is willing to share with us as well. So please look out for an email from Kojain, and we'll have this sent out pretty soon. And also, if you all are subscribed to the Kojain YouTube channel, you will already see that this recording is already available there. So, if there are no more questions, we'll gladly, this is about time.
I have a quick question. So
go
if
ahead.
the second dose is delayed, your immunity will be delayed, right? Nothing else to worry about.
The thought is you'll have some protection, unclear how much, but yeah, you won't reach that 95% efficacy that is suspected until the second dose, and even then, it's not clear exactly how benefit. We don't have data. If you give it too far apart, it's just not known, so it's not clear.
Okay. Thank you for everything.
And one last thing from my end is make sure you get vaccinated. It is safe, it is effective, and it is a way to kind of get back to normal. So I can't stress that, enough. Especially with our community, it's very important we get vaccinated given our risk factors.
Is it safe to send kids to college or school when they open but they are not vaccinated?
I mean, it's a good question. A lot of kids have already, the college kids that went to school in that first round, a lot of them got infected. It happened very quickly because it's very hard to keep college kids, secluded when they're on college campuses. Do college kids get severe COVID? Some can. It's a lot lower than, so most college kids don't die, right? So, but they can get severe infections. They still can be hospitalized. A lot of people get that long hauler. I think it's like a third or something, have some persistent symptoms. So people can have persistent symptoms and it can take some time. So, it's going to be an individual decision, but the thought is with the vaccine, with getting enough people vaccinated, can we get to herd immunity by the fall? The thought is that might be able to happen. We'll have to see how the new administration speeds up the vaccine timeline, but there's a chance that we can get, herd immunity by the time kids go back to school.
One more question I have. So does it have egg contents or anything, giants or somebody doesn't eat, take eggs or anything? Does it have anything which is like non-veg or anything like that?
These are not vegan vaccines. They're not vegan vaccines. So they're tested on animals and they may have some animal products. I can't, say specifically, what it is, but it's made out of mRNA and lipids. Some of these are synthetically derived. Some may not be vegan. So that's a thing with essentially, a lot of vaccines. So that, again, that will have to be an individual decision on that. But again, think about this from, what's the risk of not taking the vaccine? The risk is fairly high for death and fairly high. I showed that one slide of, if you get the infection, it's not just you could potentially pass it along and it could potentially go downstream. And, so doing this is not only something that you do for yourself, but it's something to protect your loved ones and your community as well.
Okay, thank you.
Nitul?
Yes, go ahead, Luis.
I just want to say last words and then we can close it up. Nirav Beda, thank you for doing this and accepting my offer to do this. Thanks everybody for attending it. I would request Nirav again, if there are some developments, new developments come up and as we learn some more about the virus and the vaccines, would you be willing to come back and update all of us at some date?
Yeah, this is my 7th or 8th one of the year. So,
I still have to ask you because I know you're a big person. So yeah, I appreciate that. Thank you very much for getting to that. Nitul, go ahead and whatever you want to say closely. And I again want to thank Neera for
Yeah, no, I think,
our offer.
yeah, I think if there are no more questions, and if there are any questions, I think we still have are about time, and we are going to end the session. Nirav has gladly shared his email ID as well. So I'll just give you one last 1 minute if there are any questions at all. Because I need to see a couple of hands been raised. So are there any final questions before we end the session? Anyone at all?
Yes, I do have.
Yeah.
Recently, the Florida doctor died. Did you have any update?
You know, I saw the headline, but I don't know the specifics on the story, so I don't know.
I think the person did not die. I think there was a false alarm that actually that person fainted, but I'm not sure if that person actually died. Yeah, I think he was just given the dose, and that's what the video showed. That he was given a dose, and after within a minute, he kind of fell off the chair. But I think that person did not die, but it was he kind of fainted.
Yeah, I think no one has died as far as I know from the vaccine, but I know a lot of people have died from the virus.
That is true.
Okay. Okay, I think so. This is we are about time. So I'll thank you, Dr. Nirav Shah, for doing these sessions. It was really very informative.
Yep.
And like a lot of us may be in line or for the vaccines, and this really helps us to whether to take the doses or not. So
definitely take it. Definitely take it.
Right. So thank you so much. And then we'll share the recording and the slides with you all. And thank you all for attending. Thank you so much. Thanks.
Thank you, Nitul, for helping.
Thank you. Yeah.
Thank you.
Thank you. Bye.
Bye. Thanks, Beta.
Yep. You
Bye,
got
Niro.
it.
Yeah.
Thank you.
Bye. Mm-hmm.